Okay, I think we should get going since we have two people to present today, which is a real treat and a real pleasure. Welcome everyone to our HIV Center morning rounds on Thursdays, and happy fall to everyone. We've now entered the new season. Let me quickly tell you about our upcoming rounds after today. On October 21st, we have Brian Dodge talking about bisexual health, more than a phase, and also Rogerio Pinto, critical consciousness is key ingredient in the fight against homophobia and sexism. And then on November 4th, we have Carmen Logi talking about intersectional stigma and impacts on HIV prevention and care cascades in different global contexts. And then the third one I'll mention at this point is November 18th. We have David Holgrave speaking about HIV and COVID public health responses, lessons from each to inform the other. So please join us on those dates, October 21st, November 4th, and 18th. So today we're fortunate to have two presenters and two guests with us today. I will introduce them one by one. And the first one who will be presenting will be Dr. Yusuf Ransome, who is an assistant professor in the Department of Social and Behavioral Sciences at the Yale School of Public Health. He received his BS from Brooklyn College of the City University of New York, his MPH in Behavior and Health Education at the University of Michigan School of Public Health, and his doctorate at Socio-Medical Sciences here at Melman School of Public Health, Columbia University. Dr. Ransome's research investigates how social, economic, and cultural determinants influence racial, ethnic, and geography-related disparities in HIV care continuum indicators and alcohol use disorders, with his current KO1 award study examining the direct association and underlying mechanisms between social capital and cohesion on HIV care continuum outcomes in the United States. Clearly very relevant to today's world in HIV research. So welcome, Dr. Ransome, and I will turn it over to you now. You're on mute.
So thank you, Dr. Remien, for the introduction, and thank you everyone for joining me today. It's a great pleasure to be here for the invitation. As many of you know, Dr. Sanford and Dr. Susie Hoffman were mentors of mine there at Columbia. So it's really a pleasure to be here and to sort of, acknowledge them publicly for their support and mentorship that they've poured into me while I was a student here. So today, again, I'm going to talk briefly about some research. My goals for the presentation is to give you a quick overview of social cohesion and social capital. Hopefully convince you why you should be thinking about it for your research and interventions, and then I'll close with some ways that we can collaborate. So to begin, I want to just tell you a little about myself and how I came to this journey to study social cohesion and social capital. And that journey began in Trinidad and Tobago, where I grew up. Before I even knew social capital and social cohesion as a construct, I saw this in my neighborhood. So in Trinidad and Tobago, it's approximately 1.2 million people. The life expectancy is around 74 years, and the GDP is about 7.5 billion. This was in 1995, during the time when I was raised there. And two things that I remember a lot was the tight-knit community. As you can see here from the picture, several houses are quite close to each other. In some cases, they're on top of each other. But one of the things I remember is my grandmother being able to send me over to the neighbor's house, for instance, for some sugar or flour or something like that, and vice versa. Another thing that I remembered is that you may get into trouble at school, and on your way home, your grandmother hears about this before you, but not only that, the neighbor has permission to discipline you. And then you come home, you get disciplined again. And those two elements are part of how we understand social cohesion, right? The indicators that we use. So coming here now to a definition, how do we understand social cohesion and social capital? Well, I'm going to use a broader framework, social connectedness. And as we mentioned today, thinking about, for example, the pandemic, the types of interventions that we are asking individuals to do, we see how important social connectedness is. So a quick definition. First, we kind of think of social cohesion as the cognitive aspects of social capital, right? So these are things like, what do you think about your neighbor, the perceptions of trust within your neighborhood, the levels of reciprocal relationships you expect from others, as well as your sense of belongingness to one's community. So whether it's a neighborhood or a physical group of individuals. The second aspect is social capital, what we know as the structural aspects, right? Thinking about the opportunities for people to form bonds. So this may be the density of organizations within a neighborhood, or the opportunities for individuals to meet up and to share some particular, whether it's a hobby or craft, or even we look at aspects that allows people to come together for advocacy. So this is sort of two frameworks to understand what I'll be sharing later. And it also helps us to think about the mechanisms through which social cohesion, social connectedness influence HIV-related outcomes. So what I've done is really take my experiences from Trinidad and Tobago and brought that into the United States to understand how does social cohesion, or what is the role for social cohesion in understanding racial disparities in HIV and also geography-related disparities in HIV. And the reason why I focus on social cohesion, not only because of personal interest, because we think about what are all the known risk factors for HIV, right? You may be asking, why study social cohesion? We already know that things like racism, institutional racism, looking at things like stigma, whether it's HIV stigma, gender-related stigma, sexual orientation-related stigma, health policy. We already know there are several determinants that are strongly associated with HIV risk at the individual level, as well as incidence at the population level. So what is the role for social cohesion? Well, I see a role for social cohesion and social capital in terms of the translational efforts. Because while we know that poverty, for instance, is a major determinant, we could think of the type of interventions like anti-poverty reduction interventions, or we could think of move into neighborhood opportunity interventions to expose individuals to different areas. But what we've known from those research is that there's a translational gap. So I'll give you one example. From the Move into Opportunity study, for instance, it's sought to address poverty by directly removing individuals from low-income neighborhoods or in situations that were where they have basically fewer access to goods and services, and brought them into neighborhoods where the housing conditions were better. They had more access to neighborhoods. And when they compared the results of those who stayed versus those who removed, they found that there were very few significant effects in terms of health outcomes. Now, why was that? One of the primary reasons they found is that although individuals had better amenities, housing conditions, they lacked that social integration that they had from the communities where they came from. So in other words, while they had all of these structural aspects, it was the intangibles, the social relationships, the opportunities to find informal agreements, arrangements. Those were the things that really mattered the most in terms of shaping health outcomes. So I see this brings us two opportunities to engage social cohesion and social capital in HIV-related research. The first is through a mediation model, where we can think of addressing the structural determinants of health, so gender-related inequalities, poverty, residential segregation, and use social capital and social community, both at the individual and community level, as a way to translate those reduction efforts to influence one's individual risk, as well as population level incidence. The second model is potentially seeing social capital and social cohesion as a moderator. So understanding how might we leverage social cohesion to make stronger the effects that we see from specific interventions and the way that they influence HIV risk and infection. And I'll share a little bit more concrete details of what this looks like in an example to follow. But for now, I'm going to talk a bit about, well, what do we know about social capital and social cohesion in related to HIV research? What we've seen from literature reviews is that more broadly, we found associations with lower unsuppressed viral load, lower incidence and transmission rates, lower HIV prevalence, in my own work, lower rates of late HIV diagnosis. But we've also seen across the studies, higher associations with ART adherence, HIV awareness, HIV knowledge, and HIV testing. And some of the mechanisms in both studies include higher rates of disclosure. So for instance, individuals who live in communities where they're able to share with others, where they're able to feel more comfortable. We found that in those situations, the rates of disclosure are higher, and then that leads to ultimately higher acceptability of testing, higher comfort with taking one's medication, et cetera. So these are a variety of different ways through which we see being in an environment with high social capital and social cohesion translates into the HIV-related outcomes. And then psychosocial stress is a main mechanism. This is part of what we are seeing today during the pandemic, for instance, how living in environments where individuals or there's a lot of tension, we tend to see those areas have lower rates of vaccination and higher vaccine hesitancy among individuals. So I'll go into depth with one example, and this is something that happened to me recently, where I moved into a new neighborhood in New Haven. And one day I ordered a package that came to the house, and I got the notification on the phone that your package was delivered. And so I went downstairs, looked in front of the house, no package. When I looked more carefully, the package was delivered to someone else's house, right? And so when I looked, I said, well, okay, surely the package couldn't be that far away because the driver was in the area. And so I kind of walked around, started looking around to see if I recognized the door, right, for the house or the package. But then I thought to myself, wow, this is really strange, right? Like, why would somebody take this package? They see your name and address. So obviously, if they're a few blocks away, they can, come drop it off or call UPS to pick up the package. And so that really translated into me being stressed out. And when we think of social cohesion as the perceptions of community togetherness, the perceptions of trust, I immediately start thinking about, well, my neighbors can't be trusted. What are people like in this neighborhood? So although I just use this one particular scenario to develop these host of hypotheses, right, based on this one situation, imagine living in an environment where this is constantly occurring. It may not be the package that's stolen, but it may be something that's related to your perceptions about individuals within that neighborhood. From the structural aspect now, we'll think about what if I needed some specific resource, right? And let's just assume, for instance, this package contains some essential medications, or I used my last bit of funds to buy something for my children or grandparents or someone else. And now I'm out of this money, I'm out of this package, and there's no way to replace it. So think about, well, who do I call in this situation, right? What are my networks like? Is there anyone in my neighborhood network that I can perhaps go borrow something from or say about the issue? And so if we play along with the story, we can see that, well, maybe for this particular person who lost the package, it means calling up someone from their network who they would have liked to avoid. Let's just say it's a young female and maybe calls up her ex-boyfriend or someone else in her sexual network that now she has to give a favor in order to get the funds to replace the package that was lost. So again, this is kind of like a long drawn out example, but it's just to kind of illustrate that over time, these sort of settings that contribute to the levels of social capital and social cohesion in one's neighborhood may have downstream impacts on HIV-related risk behaviors and ultimately HIV incidence. So I'm going to share some results from my work to date, and then just kind of go into where I see the gaps and opportunities, and then more broadly into interventions and how you can use social cohesion and social capital in your work. So I'll share 3 studies that I've done. The first one is in New York City, where we looked at social cohesion in an ecological study, looking at measures from 2005 and 6 and linking that to late HIV diagnosis rates in 2009 and 2010. The measures that we used included the perceptions of trust in one's neighborhood, collective efficacy, social control, and civic participation. And so we found that higher informal social control in one's neighborhood, in zip codes to be specific, was associated with lower rates of late HIV diagnosis among men, higher political participation, which is the rates at which people participate by contacting their local congressperson, for instance. In those communities, there was an association with lower rates of HIV diagnosis among women. And then we found higher social cohesion in some neighborhoods was associated with lower rates among women, but not among men. In the second study, I conducted also an ecological analysis by looking at similar social cohesion indicators in relation to rates of late HIV diagnosis at the census tract level. And what I found is that social participation or higher rates of social participation in those neighborhoods where people came together to do events and participate in events, those neighborhoods tend to have higher rates of linkage to care. But on the flip side, we found that in neighborhoods where there's higher collective efficacy, there seem to be lower rates of linkage to care. And we were still trying to understand these. And one of the potential explanations, of course, is reverse causation, where you're dealing with cross-sectional data and you can't determine which preceded which. So that's what we think is happening there. The third study, and this kind of brings in the role for geography as well as linking this to race and ethnicity, is another ecological study conducted at the state level where I looked at the role of social trust, one specific indicator of social cohesion and its association with rates of late HIV diagnosis across transmission group as well as across race and ethnicity. What we found is that higher social trust across states was associated with lower rates of HIV diagnosis more broadly. But what was important is that the strength of that relationship varied, and it was stronger for Black compared to white individuals. So this kind of leads into my original hypothesis and interest in this work is that can we leverage social cohesion to reduce racial disparities in health? So this was kind of one of the first indicators that there may be some promising role for using or leveraging social cohesion in this work. And then finally, the point that we look at when we think about, well, why study social capital and social cohesion within the risk of other determinants like segregation, income inequality. But what was striking from this finding is that social cohesion was a stronger predictor by just looking at the predicted probability of HIV diagnosis in those neighborhoods. The coefficient was much stronger for social cohesion compared to traditional indicators like resident segregation, income inequality, and even socioeconomic deprivation. So what are some summary? Where do we need to go from here? Well, based on another literature review that I've done, so far we've seen that most of the work on social cohesion and social capital in the US has been focusing on HIV diagnosis, some on adherence, but there's room to study its association with viral suppression and other indicators across the care cascade. What we've seen also is that most indicators tend to focus on trust, social cohesion, and civic participation. Now, there are a few gaps that I'm going to be pursuing in my future work. One is that not all constructs are available across studies, right? Or not all are conceptually relevant. And so oftentimes this means that you're trying to develop some conceptual link between the measures that you have and the specific outcome. And we know that it's best to have theory-driven research, but it's not always the case in dealing with the type of data that you have. The second is that the data aren't always together. And so for the ecological studies, for instance, I've been linking social cohesion from an independent data set, typically some health survey, to HIV-related outcomes from the HIV surveillance databases. But they're not often in the same place where we can look at social capital among individuals with HIV and that. The third is that race and gender are not always studied or stratified. As we can see with two of the studies that the associations vary when we broke it out by gender, or we conducted effect modification analysis by race. And then I'll just go on with saying that existing measures do not allow us to study both the individual aspects of social capital as well as the collective aspects of social capital. So you may be asking, well, why study social cohesion? What is the role? Is there any relationships with HIV-related interventions to reduce incidence or transmission, or think about other sexual-related behaviors? And so I'm just going to share three results since I haven't conducted any interventions personally. But these are three sort of selected studies that are showing some promise or have shown some promise for using social capital and social cohesion more broadly in HIV-related research. The first is a study that was conducted in South Africa, a randomized controlled trial in 8 villages, individuals 14 to 35 years old, and they examined both the structural and cognitive aspects of social cohesion. And what they found is that in males, higher cognitive social capital, so this is trust and relationships with individuals, was associated with lower HIV prevalence and higher condom use among males, whereas structural aspects of social capital was associated with higher HIV infection among women. And the authors didn't really explain why this was the case, but I'm happy to go into some explanations afterwards if you're interested. The second project was conducted in Tanzania, but this time focused on key populations of female sex workers. And they've also used similar indicators of social cohesion, but mostly focused on community-based organizations and providing HIV training curriculum at community-based organizations and encouraging local residents to participate. And what they found is that female sex workers participating in the intervention had a 30% lower risk of HIV infection 18 months post the intervention. So this is quite promising. And then finally, it was another intervention that was this time focused on closing the gap in gender-related disparities, but also expected that closing the gap would be directly related to a reduction in HIV incidence among women. And their social cohesion intervention included also participating with community-based organizations, but the curriculum was focused on reducing gender-related inequalities, but they encouraged men, families, and other locals in the community to join in, and for individuals to use text messages to support what was going on in the community. And so what they found is that men in the intervention group versus controls had higher condom use and higher HIV testing at follow-up, and a similar direction of association among women, but a smaller and non-significant effect. So what are some ways to use social capital in your interventions? The first is social capital as a target. And this is where it includes activities that build or strengthen relationships, bonds across people, advocacy, help people gain trust, reciprocal relationships. And we can see that that may have a direct relationship on the specific HIV outcomes. The second way is to think about social capital as a channel. So as I mentioned earlier, oftentimes we may want to target an intervention focused on poverty or gender inequalities or some other structural mechanism, but we can use social capital as a way to deliver that information to the community. And so what are some modes of delivering the social capital interventions? So first, we've seen traditionally that this involves some person-to-person contact, whether it's individuals in a community, using community-based organizations such as churches or schools or other nonprofit organizations. But what I want to push is for the integration of online with in-person. And we've seen the need for that during COVID, right? Where several of my colleagues who I know doing work in New York and elsewhere had to quickly pivot to find ways to actually deliver their content to the participants that they're serving. And this involves some online activities, or for the most part, at least the bulk of the intervention turned to be online. And a second promising route is through the use of mobile games, where we can sort of create a virtual environment that allows the individual to be able to practice or model behaviors in an environment that's fun and safe, and be able to boost self-efficacy and confidence. And then the third way, which is something I'm quite excited about to incorporate in my work, is through a hybrid of partnering with business. And we've seen the importance of this, again, during the pandemic. Traditionally, public health research, we are mostly doing interventions on our own. We are designing, we are implementing, but we see that there's a strong role for business, which for the most part tend to do things really well. So for instance, when we look at the logistics of delivering the vaccine, right? The partnership between public health and Amazon, for example, their logistics of being able to get packages really quickly, we've been able to borrow or leverage their technology to get vaccines in the places that we needed them quickly. So how can we think more about the role for business in our intervention, specifically where it comes to considering building social cohesion and using that as either a channel or intervention? And there are two ways. There are some companies that are focused on social entrepreneurship, so they have some social mission, but then there is the social enterprise model where the company is built from the ground up to focus specifically on a social good. And again, I'm happy to talk more about this in the end. So as I close, ways to collaborate with me, right? So I've given you a quick overview of why I'm engaged in social capital research, a personal history of how I came to study this, the potential role in HIV research in the United States, what we've done so far, the findings from the interventions globally. And so as I go forward, I invite you, if you're a researcher, we can work together to identify existing skills and use existing social capital measures in your current studies that probably are in design or maybe under review or even in the field. I can help develop qualitative studies to identify new measures. So as I mentioned, not all of the measures are salient. Most of the social capital and social cohesion measures were developed in political science and in the criminology field to understand crime and these other indicators. And we have borrowed them basically to study the relationship with HIV. So can we do better? Can we find measures that perhaps are more salient to the specific outcomes that we are focusing on? I can help you design social cohesion and social capital models to augment to any existing relationships or interventions that you may have going on. But then I could also help you identify potential opportunities to partner with corporate and business to, again, leverage these social enterprise and social entrepreneurship models. And if you're a doctoral student, I have some existing data sets that you could analyze together and write papers, but I can also help you with conducting original research if this is a topic that you are interested in pursuing for dissertation or some other postdoc or something. And this is all I have for you today, but now I open it up to invite you for specific questions that you have for me. Thank you all for the presentation or joining in today.
I'll turn it over to Stephen, but just want to say thank you for a really excellent presentation, Dr. Ransome. That was really fascinating. Thank you. Over to you, Stephen.
Thanks, Bob. So as a reminder to everyone, if you have a question, you can enter it in the Q&A feature or raise your hand to indicate you have a question, and I'll unmute you.
Stephen, I wouldn't mind opening up with a question.
Sure.
Yusuf, very interesting story and a very hopeful story in a way. And I was wondering though, whether your story is not too hopeful. And I was wondering, well, could social cohesion also lead to the opposite effects, to negative effects in a way? You know, we're living in a very divided country at the moment. And I assume that if we would study social cohesion among the anti-vaxxers, we would find high levels of social cohesion. With other words, the social cohesion does not necessarily lead to positive outcomes. I would be curious to hear your thoughts about that.
Yes, so thank you for that. And that's an excellent observation, right? So indeed, there's sort of the dark sides of social capital, as Alejandro Portes writes about, right? And so it is true that there are some negative aspects of, or ways, I wouldn't say negative aspects of social cohesion, but negative ways in which it's used. And I'm actually thinking about some work of one of the persons that you're going to invite, Dr. Holgrave, who did a study in the United States back in the day, and he found a negative association with HIV risk and hypothesized that, well, it could be that people are too trusting in some places. And so they, let's say, assume that, okay, this person is telling me the truth. And so they go ahead. So that is correct, right? But what is hopeful about this, and actually I'm quite pleased to just share that I'm going to be speaking at APHA on the topic, is that we recognize that there is still an opportunity, because what we've done in the past so far is there's really been a lot of passive social cohesion happening, right? So individuals were kind of allowed to develop their own agenda, and there weren't really checks and balances. But major organizations, for example, APHA, is sort of looking at this role to take charge of social connectedness and social cohesion. So in other words, not to let it run wild in terms of folks doing what they're doing over here, everybody has this agenda, but how can we as a public health institution formalize this? So we talk the same way about, or I can use an analogy, for instance, of racial discrimination. We've tended to kind of focus on the individual aspects, the person-to-person contact, but now we are really taking seriously the structural aspects. How can we look at influence and structure to affect the individual behaviors? So I think that while indeed it's going to be a long road going up, I do believe that there are ways in which we can strengthen our institutions by two ways. First, focusing on, from a policy perspective, on opportunities in neighborhoods and elsewhere to really develop those positive aspects of social capital, or the things that may lead to positive outcomes through direct funding for community organizations. So there's example of things like the PPP that allowed organizations and businesses to stay open during the pandemic, recognizing the need for that social interaction. But also from the cognitive aspect, how can we as a public health institution and intervention or institutions more broadly shape an agenda that really builds the narrative that individuals in the community are the people that you're going to rely on? Because I want to argue, at least believe, that we all started off from a good place, but across time, because there weren't sufficient checks and balances, everyone was kind of left to develop their own narrative. But now I think we have an opportunity to reshape that narrative. Like, we are who our community is what is going to protect us in times like the pandemic, where you can go knock on your neighbor's door to find out if they need a ride to the hospital. There's so many stories you've heard about neighbors who came home and found their neighbor dead or something like that, right? How do we change that? And then there's evidence from other societies in Japan and elsewhere where social capital has been formalized, not just left to the individual, right, but formalized from several institutions as well as government. And this has really resulted in phenomenal positive impacts on health outcomes. But that is correct. I do see the role for caution, but also the optimism that we can change things.
Thank you, Yusuf.
We have a question from Patrick Wilson. Patrick says, thanks for a fantastic presentation. Have you considered the difference between physical and virtual social connectedness and the potential impacts they have separately and together on the outcomes you are examining? With so much social behavior happening online, I wonder how you think online social connections compare with physical or geographic specific social connectedness, which are great examples of living in Trinidad and New Haven primarily spoke to.
Thank you so much, Patrick, and thank you for joining the presentation for your question. So this is, again, it's a fantastic opportunity, right? So to really move social cohesion from the traditional ways of studying it as these household-based surveys, looking at these metrics of direct participation. So for example, Grant Votter, a sociologist, found that we don't necessarily need strong ties to have the positive benefits of social cohesion. So in other words, weak ties, sometimes tangentially knowing someone or having some resources or people or in social networks at the fringes, it's sufficient enough to obtain that outcome. So in the example online, for instance, where you're using the analogy between connecting with folks in Trinidad, my family, and here in New Haven, that is one way to build that. But what we also see is that for some populations, it's still not going to be sufficient, right? It may be a stopgap or something that we can leverage, right? Certainly we can do better in terms of the social networking platforms. And I'll just kind of throw two platforms out there. And I swear I have no disclosures to inform for either company, but we've seen stories, for example, from Meetup or the next app called Nextdoor. Many of you may be familiar with those two apps, for instance. They're able to use them. So I'll just talk about for the Meetup example, where they have been formed to use the online networks to develop in person. So you go online, you meet up with friends, but then you meet in the park, for example, for a hike. But during COVID, they had to basically flip their model to focus directly online. But what you've seen is that it wasn't really the transition of their business entirely. They're still focusing on getting back. So I do believe that there is a role for online, getting back to the community. Another example for Nextdoor, right? During the pandemic, they were able to find a way to partner with Walmart, for instance, to identify vulnerable individuals in communities who perhaps could not go to the grocery store or were at high risk for going out. And so this partnership from online to this enterprise, they were able to find a way to deliver groceries to those individuals. So there's been a number of creative solutions that have leveraged the online space, but still not separating it entirely from the physical need for people to have interaction. So this is a great question, Patrick, and there's certainly a lot of opportunity to, again, think more carefully about how can we integrate business in public health related agendas. So that's kind of what I'm excited about going forward.
Thanks, Yusuf. Any other questions? Looks like someone has their hand raised.
Theo has his hand up.
Theo, go ahead.
If there are no other questions, I have another one for you, Yusuf. You showed a moderation effect of race in one of your studies.
Yes.
And I think, if I remember correctly, the relationship that you showed was stronger for Black people compared to white people.
Yes.
Any ideas why that is?
Yeah, so actually, it's interesting because I found that in two other studies, one related to HIV testing and a separate study related to COVID-related infections. And so I believe that when we think about how do we get the resources, so for example, we focus on entrepreneurship activities or poverty reduction activities, right? So let's just say, okay, actually the perfect example is the PPP loan, right? So thinking about using this poverty reduction tool to assist Black entrepreneurs and communities to access capital to help keep their businesses alive. So if you were to stop at the mechanism of just giving out those applications and assume that information is reaching all populations correctly or sufficiently, what we would find is an unintended consequence of disparities, because what I have found with a person who considers himself to have high levels of network and resources, I still had to do a lot of work to be able to find out how to use the PPP. How do I go on this application to the website to fill out the application? So I had to engage my networks and the social capital that I had, right, to be able to find out how exactly to take advantage of this anti-poverty reduction tool. So my hypothesis is that while there may be these sort of opportunities, if you will, or in places that I think, for the most part, or at least in these studies, that it's necessary for that additional support for the Black population, right? That the social cohesion is more important for them, because that's how information is shared, right? There, we look at the rates of internet ownership or household internet use among African Americans, typically lower than white Americans and other groups, right? So if you think of or assume that everyone is going online to find information out, then it's probably a wrong assumption, because perhaps in the Black community, that information is shared verbally. So we have to really kind of take these things into consideration when we develop these structural level interventions, to not allow necessarily the assumptions to go unchecked, right? And so I think that's why I see the role for social cohesion as being so important in the Black American community, and its influence not only on HIV-related outcomes, but on social mobility and a host of other indicators that I've studied so far.
That's really fascinating, Yusuf. Thanks.
Thank you.
Any other questions? If not, Bob, I'll turn it back to you to introduce our next speaker.
Okay, thank you, Stephen. And thank you again, Yusuf, for a very, very comprehensive, thoughtful presentation. And so we're moving on to what I know will be equally excellent presentation from Dr. Tara McKay. Dr. Tara McKay is a sociologist and assistant professor of medicine, health and society at Vanderbilt University with a secondary appointment in health policy. And she's an associate director of the Vanderbilt LGBT Policy Lab and is principal investigator of the Vanderbilt University Social Networks Aging and Policy Study, which is funded by the National Institute on Aging. Dr. McKay received her BA in psychology from Occidental College, her MA and Ph.D. in sociology from the University of California, Los Angeles. And before joining Vanderbilt, she was a Robert Wood Johnson Foundation Scholar in health policy research at the University of California, Berkeley, and University of California, San Francisco. So as you will see from her presentation, her research examines the social and policy contexts that shape health among sexual and gender minority populations in the US and African contexts. Over to you, Tara, welcome.
First, unmute myself, thank you. There we go. So I'll be discussing today, you're reviewing my screen, hopefully, there we go. I'll be discussing today how we can think about linking all of the work and effort and organization and resources that have gone into HIV research and policy, and how those have actually affected LGBTQ populations throughout the global South in terms of advancing social justice goals that these organizations and individuals and communities have through some of their work. And this is coming out of a few different publications, papers, work that are ongoing over the last decade or so that think about this for individual case contexts, like Malawi, Senegal, have almost published work on Nigeria, Mozambique, that's also thinking about how LGBTQ visibility has been linked to work in the HIV and health sectors for international development. And also more broadly, kind of what's going on at the level of global health governments in terms of thinking about prioritizing men who have sex with men, how these priorities have changed over time, and what their downstream effects have been for organizations and people on the ground. So I'll kind of be painting with broad brushstrokes here to give you a sense of several of these pieces, but for more in-depth reading, I can certainly refer you back to some of these. And after working in this space for a while now, I have kind of this lingering question that I continue to add to about how HIV research funding and policy prioritization targeting men who have sex with men has been affecting social justice work for LGBTQI folks in the global South. Is this creating new opportunities? Is it expanding existing ones? For who, and how much, essentially? And this comes out of some questions that are in the social science of global health, the critical global health literatures that kind of think of this space and these resources and efforts broadly as kind of having a contested role here, as having both pluses and minuses. So for example, on the one hand, this kind of massive increase in resources towards HIV and more recently targeting men who have sex with men has expanded resources for grassroots organizations that want to serve LGBTQI populations. It's generated certainly visibility for some of those populations, though not all and certainly not evenly. It's generated new accountability structures at this global governance level and at the national levels that have linked funding and health outcomes to engagement with LGBTQI populations and men who have sex with men in particular. It's also expanded training and professional opportunities for our colleagues in the global South. At the same time, there are some costs here that scholars have noted, which is that this momentum, this prioritization, this visibility has expanded state surveillance of sex and sexuality for LGBTQI folks, and that this has circumscribed grassroots LGBTQI movements that want to work on stuff besides health and HIV. So on generating visibility for sexual diversity, for thinking about sexual pleasure beyond a health context. There's also research that I've engaged with that thinks about how the push and focus and prioritization of men who have sex with men in the HIV context has emboldened state and non-state actors alike in their persecution of LGBTQI populations and communities at very local and national levels. And then finally, in this space, there's kind of this broad observation that it's really mostly advanced things for gay and bisexual men and other men who have sex with men, and really left lesbian, bisexual, and trans women out of these organizational spaces. And so one of the things I want to give you today is this deeper, longer story of how this became our reality and some of the systematic consequences that have come out of this. I'm also going to tell a somewhat hopeful story. Hopefully we're not too hopeful, but maybe we all need something a little hopeful. I've been in this disparities landscape for a while now, and I need something hopeful. I live in a red state too, right? We need something hopeful. So here's the timeline just to kind of give you a sense of what has been going on for the last 40 years, right? We're on the 40th year anniversary of the description of the disease that came to be called AIDS here in 2021. What's been going on in policy and kind of our understanding of this disease, the meanings of it, and so on. And so just to move through this timeline, this is again broad brushstrokes that you can find in a few different papers that I've written, where we think about this initial kind of setup of the epidemic as looking different in different places. So you're looking at this map from 1986, 1988 paper by Chin and Mann that's setting up this dichotomy where in one space we have mostly penile vaginal transmission of HIV or injection drug use, and on the other side we have same-sex sexual transmission occurring more frequently. And this is really divided in terms of how we think about policy, how we think about interventions. There is some of the historical work that I've done suggests that there is this tension for the folks in this space, working in this space, moving these policies and programs at the time, where they know that same-sex sexual transmission is likely to be an issue in spaces where they're not kind of considering it. but they don't have any data, and diplomacy and getting programs running in an epidemic take precedence. And so these things just kind of percolate for several years, right? There's concern here. There's not a lot of data. There's really only this ability to kind of think about men who have sex with men in a few very limited contexts that some of the folks in the room have been contributed to, and so on, in Brazil, in Israel, and a few other contexts that help people to continue to think about this during this time period, but really don't get this more broadly applied. Right? And so in this next period, this 1998 period, there is this move to think about men who have sex with men, not just as this piece that needs to be separate from, but as whether it's primary or secondary, is certainly something we need to be paying attention to. So this comes out of the launch of UNAIDS and folks there paying certainly more attention to men who have sex with men in the HIV and AIDS programming that they're hoping to launch and develop in terms of policies and so on. There is still this massive lack of data, but there is a little bit more political will here, institutional will to take this on to ensure that countries try to start thinking about this. There are also failures during this period where the 2001 Declaration on Commitment to HIV and AIDS, led at the UN General Assembly session, fails to include any mention of men who have sex with men. This gets struck from the draft in the final version. And so there are certainly movements here that try to advance prioritization of men who have sex with men in the HIV space, in the global governance space, but fail, right? What's different a little bit later on here in this space is that because of that 2001 declaration, there are new accountability structures. There are new strategic collaborative changes from actors within the UN system that are trying to change their own institutional cultures, that are trying to change how they work with governments, that keep kind of bringing this issue up, even though they don't really have the data and they don't have any way to enforce countries to prioritize men who have sex with men at this time. But this opens the door. And so by 2006, 2007, we end up with this statement that empowering men who have sex with men and marginalized groups to protect themselves is one of the world's most urgent health priorities. So we go from this very early period, this is not an issue in many epidemics in all of the sub-Saharan African region, Caribbean, and so on, to this is the world's most urgent health priority. And what's really changing here in this moment is that there's new data, there's new funding availability, there's actually requirements that countries report on their progress towards reducing HIV among men who have sex with men. Even if that progress is zero, they have to state it, and it's public. There's also some strengthening of these accountability structures and new global actors that ultimately, a little bit down the line here, do take up this mantle in terms of making sure that men who have sex with men, for example, are incorporated into the Global Fund's country coordinating mechanisms, that countries have to have these groups represented in their national plan in order to get global fund planning or funding. Sorry. So some of the work that I've done is tried to look at how all of these changes at that kind of 30,000 foot level and that policy level actually shape what countries do. So what you're looking at here is excerpts from these country progress reports that they are recommended to submit to the UN, to UNAIDS every few years. They kind of reporting year increments change over time. And they are intended to respond to, again, this question of how they are reducing HIV among men who have sex with men. And they're given some exact kind of parameters to report, as well as a narrative statement option. And so this is the narrative statements from countries that essentially are not including men who have sex with men at the time period that you see noted. So this is an example of what things that you might see, anything from not applicable to these are not among the most at-risk groups in our country. This is not recognized as a problem. Two, we looked for them, but we couldn't find them, essentially, as the short version here of the two that you see on the right side. We don't have any data that suggests this is a problem, essentially. So one of the things that I've been interested in is how this actually changes over time. So what you're looking at here is a graphic representing that transition from we don't have any inclusion of men who have sex with men, we don't recognize this group at all as a most at-risk group, to, okay, this orange color where we're going to start planning some activities. We're going to acknowledge that this is a category that we don't have a lot of data for, but it's something where we need to be providing more information or studying or surveilling. Or even we're going to start planning a surveillance study, even if it's limited to the the capital region or something like this, right? We're going to start doing that. And so over this last 2 decades, you see substantial adoption of this. We're going to start doing something, or we're piloting something. We have things active in a small geographic area or for a very small targeted population, essentially. So all of this accountability, all of these kinds of other structures kind of changing, I think is having the effect of, at least on paper, moving countries towards acknowledging that they may need to actually incorporate men who have sex with men, or they're actually doing it in a pilot or limited initial early stages kind of way. You'll notice that I also include this idea of they've got ongoing, well-established, widespread activities. That's certainly much less occurring here. And that's maybe one of those lingering challenges. This bottom category as well has gotten very sticky. So groups that are not including men who have sex with men, sorry, countries that are not including men who have sex with men, that category is getting stickier over time, right? So if they aren't including it in 2013, they're very unlikely to be including it in 2015, 2016, and so on. What's funding got to do with it? So beginning in about 2008, the Global Fund made some significant changes in over time, incrementally, in how they were going to incorporate men who have sex with men. They even later had rounds of funding specifically devoted to keep populations and men who have sex with men. And what I found is that the support from the Global Fund as a % of government expenditure for low and middle income countries is linked to an increased likelihood that they make that jump from not acknowledging men who have sex with men in their country progress reports to including them in a limited early stages pilot kind of way. And that transition probability is a little bit different if same-sex sex is legal versus criminalized in the country that we're talking about. But essentially, this funding is having some effect, right? Lots of countries are kind of in this space here in terms of how much funding that Global Fund is providing relative. We have very few countries that are up kind of in this corner over here. And so it's not a huge jump, but if we have a treatment effect of like between 5 and 10% in a lot of spaces, that is something that we're excited about. And so the idea that funding here is kind of changing that landscape, I think is happening, certainly a little bit more so in countries where that legal system is more acceptable for incorporating men who have sex with men. And it's not just kind of in the quantitative data that we see this. So some qualitative work that I did in 2016, 2017, 2012 in Malawi makes these links as well. So this is an interview with a member, this is a pseudonym, a member of the Center for the Economic Development of the People in Malawi, which works on human rights issues related to sexual minorities. And so in this interview, one of these representatives stated that within the Global Fund, they're pushing human rights agenda to the forefront. So if the language is, if you don't recognize sexual minorities, the rights of sexual minorities within your HIV prevention programming, then you may not get those funds at the country level. So UNAIDS is of the same opinion. Some of the key Global Fund partners are also of the same opinion. And again, if I'm not wrong, our Ministry of Health is also heavily funded by donors. So they make this connection between all of the international development organizations kind of having this same platform to the Ministry of Health kind of being encouraged to adopt men who have sex with men as a funding and programming priority, even though in this moment in Malawi, the laws were criminalizing same-sex sex, and they had actually just come out of a very high-profile criminal trial of a man and trans woman who had an engagement ceremony. How does this kind of relate to broader LGBTQI communities? So I want to give you a little bit of sense of that as well. And the first part of my things that I would like to convince you of is that HIV funding, policy, research practice, these things, these efforts, this money changed what was counted. Counting changed what was counted here. And what I mean by that is that men who have sex with men in a lot of these contexts, especially the ones that I work in sub-Saharan Africa, did not exist as pre-constituted groups in many cases. They weren't already organized. There were networks, sure. There were even maybe informal, not recognized, not registered organizations, but there was not this kind of out visibility movement and so on. And so the statistical visibility that HIV kind of offered to this, to individuals that became a community here, were that they could be visible anonymously, that they could be visible in surveillance reports and surveys and other kinds of activities at the National AIDS Commission or Ministry of Health meetings. And this spurred new conversations about sexuality, recognition ultimately, even though there's some resistance and hesitancy, certainly in those rooms, about acknowledging same-sex sexualities, but it spurs conversations here. And ultimately, this leads organizations in several contexts to become more involved. They get a seat at the table. So this is another excerpt from that Malawi paper, thinking about setup officers actually being invited by their National AIDS Commission to present their work at national conferences, to present their work at Ministry of Health meetings. This is a different person describing how, if you read the NAC work plans since 2006, when this organization was formed, you'll notice that in all the major national plans on HIV and AIDS, they mention working with MSM and all that. They were actually literally copying and pasting some of the statements that were in setup reports into their policy documents. And so while the Ministry of Health, the NAC, et cetera, governments aren't necessarily doing this work on their own, they are kind of transporting it. They are having these conversations. They are recognizing the need for these groups to be in the room and having those conversations, even if they're kind of being encouraged to do so by funding priorities and so on. I would also argue that HIV funding policy and research has provided a catalyst for the constitution of cohesive identities around sexualities that have created new organizations and movements. This is certainly more the case among gay and bisexual men and men who have sex with men, but it's not limited to this group. And I'll give you a few examples as to how. So some of the projects that I worked on have looked at, done a census of LGBTQ serving organizations in the African region. And as of 2017, there were 140 organizations serving LGBTQ populations in 38 African countries. And while the earliest of these were formed in the early and mid 1990s, the majority, well over 60%, were formed in the last 10 years. So they're less than 10 years old in 2017. The majority were led by gay and bisexual men or MSM. And when interviewing folks responsible for the founding of these organizations, we hear the same kind of origin stories across countries. Typically in this like modal period of 2005 to 2008, our friends were dying. We had to do something. This usually starts with condom distribution, information distribution, and so on, taking community members to the doctor and expands from there. But this statement that is so reminiscent of, our early 1980s period in terms of thinking about mobilization around HIV and AIDS for the gay community in the US is very similar here. And that tone is so similar. It's hard to hear in these interviews. Our friends were dying, we had to do something. And so we see this massive growth in organizations serving LGBTQ populations. A lot of it is led by gay and bisexual men, MSM. But we do see some other kinds of organizations, which I'll show you in a minute as well. Importantly, there are still no organizations that are open, that are visible, that are identifiable, again, from a somewhat outsider's perspective, in at least 12 African countries. And so this is actually fairly high compared with other sources, like Outright International has another census. But it's also very different for the African region. So in the Caribbean, Eastern European regions, this is much more common that organizations are registered and openly LGBT serving organizations. In the Asia Pacific region, there's a whole lot of organizations, but most are unregistered. For example, in Indonesia, only 1 of 41 LGBT serving orgs in these censuses is officially registered. Importantly for the African region, HIV has provided a way around these laws prohibiting registration of civil society organizations by creating this loophole that they can register as addressing key populations affected by HIV, including men who have sex with men, and they may or may not include that last part in order to not attract too much attention. A case study of this to show you just exactly what I'm thinking of here is for Nigeria. So in Nigeria, in our kind of present day context, there are 19 MSM or gay-led organizations that are mostly formed after the emergence of HIV among MSM in about 2005 or 2008 or later. The kind of most prominent of these is the Initiative for Equal Rights called TEARS. And TEARS was established in 2007 as a response to this continuous discrimination and marginalization of sexual minorities in health programs, such as HIV prevention and human rights advocacy. In the same context, we see 5 lesbian, bisexual, and trans-led organizations or groups. In talking with some of these groups, they view the MSM-led organizations as really the boys' club, and they form their own organizations in response to their lack of inclusivity. Importantly, several of these organizations are much more precariously funded. They operate on tens of thousands of dollars instead of hundreds of thousands of dollars per year, and they focus much more on empowerment, on economic independence, and community members' kind of well-being and human rights reporting than on health. Some of these LGBT organizations that we've kind of thought about and linked to and connected with predate increases in HIV prevalence among MSM. And I would argue that these organizations actually look fundamentally different today than they did when they were initially started. And so I have several examples of these that we could think about, but I'm most familiar with a case study from Mozambique where there has been for some time just one LGBT-led organization. It's primarily been focused on community building, education, and rights advocacy. It has historically had lesbian, bi, and trans women in leadership positions, and now conducts HIV prevention and testing primarily to fund their other key activities in education, advocacy, and communication around sexual rights. And ultimately, they've been able to leverage their existence as really the only organization in Mozambique for quite some time to push their funders to expand budget support for non-HIV testing activities. Finally, I'd like to think about how international development partners have increasingly been broadening their missions and key populations to be more inclusive of lesbian, bi, trans, and intersex-led organizations and the rights work that the community wants to do. In some contexts, this has come from the visibility and success of HIV-funded MSM organizations, which has propelled a cascade of new organizations working on rights and advocacy for other identities. So thinking about Malawi here, For a very long time, 2006 to 2015, there was one MSM-led organization, the Center for the Development of People that I mentioned earlier, that focused on sexual health and rights of minority populations with a primary focus on men who have sex with men, but they did also some other work with sex workers and so on. Their visibility, their success, their increased and other increased broadened funding opportunities kind of in the background have created an opportunity structure that has enabled several new groups to be born essentially into this space. So there are now 4 additional organizations working on different aspects of sexual rights advocacy, working with lesbian, intersex, and trans women, working on male sex workers in particular, working on intersex advocacy, which we don't see in a lot of these contexts. So it's really created and opened up this space along with more diverse funding opportunities. So some closing thoughts here I'd like to leave you with are that the formation of LGBTQI organizations in the Global South and in African countries in particular are deeply tied to the history of HIV funding, policy, and research. And in the past 2 decades, this funding policy and research targeting same-sex sexual transmission has really structured African LGBTQI organizations in a very particular way. It's also provided a catalyst to constitute organizations and groups around their community identities, and also created new loopholes for them to be able to register their organizations and do the work that they do. It's encouraged some formation of new lesbian, bi, and trans-led groups, and shifted the day-to-day work and priorities of older, more inclusive, rights-focused organizations. I would say also recently, in the last 3 years, some of this kind of initial barrier breaking and funding diversification have led to the birth of new LGBTQI rights and health organizations that potentially help to diversify LGBTQI movements across the Global South. Thank you so much. I look forward to your comments, questions. Hopefully I'm not too hopeful for you. I do have lingering concerns, of course, that I'm happy to address, but I'll leave you with that kind of hopeful social justice movement kind of piece.
Well, thank you for the optimism. And again, thank you for a very thoughtful, excellent, and important, very important topic, very important presentation. So I'll turn it again to my colleague, Stephen Sukumaran, to monitor and do the Q&A.
Thanks, Bob. So everyone, again, if you have a question, please enter it in the Q&A feature or feel free to raise your hand. Theo?
That's probably no surprise there that I was going to ask a question. I really enjoyed your presentation because it puts our day-to-day work as social researchers into a much larger context that we usually often forget. Your presentation reminded me of the fact that when I started working in South Africa in 2005, nobody was able to tell what the prevalence was of HIV among MSM. In a way, a lot of people ignored the existence of the category, so that illustrates your point. And it was even the case in 2005, so that's shocking. And it's good to see that these positive developments are there and that they are driven by outside forces to a large extent. You had, on one of your slides, you had a reference to your paper about backlash. And I hope you can talk a little bit about that, how we have to understand that, and also in relation to that, what the role of outsiders is and how that is being perceived in the countries.
Absolutely. I think that's a great question. I think also your perception that there just really wasn't any information on prevalence is totally supported in everything that I've seen and looked for and so on, right? For like basically 20 years, we did not ask about same-sex sexual activities in sub-Saharan African contexts. There were, 1 or 2 very early things and maybe a few things happening in Senegal and Cameroon in those early 2000s, but really we were not asking, like we just didn't ask the question. So we didn't have the information. And that I think is definitely reflected in several kind of people's stories about this period and so on. So let's talk about backlash. So certainly, this is a hard piece, right? We do our work. We don't want to cause problems for folks, but that visibility in surveillance and reports is not something necessarily that the community can control. And so, and is also brings up, conflict in terms of political conflict and so on, about how governments feel and think about these issues. A very typical trajectory is that, a group like Setup, for example, does a survey. They find 100, 200 or so men who have sex with men. They report on HIV prevalence. This is kind of happening in the 2005, 2006 period. They tell NACA, right? They tell the Ministry of Health, this is what's going on. This is important. Look, we have this massive population that you never thought about. And a significant portion of them are HIV positive, right? 20%, 30% are HIV positive. We need to be paying attention to this and doing more surveillance. It's written up in the paper, as a report. Regardless of what happens in that meeting, it gets written up at the paper. And all of a sudden you have a lot of news media and discussion going on about mostly gay and bisexual men in this context, which foments a lot of curiosity, actually, I think. I did a household survey on attitudes towards homosexuality in Malawi right in this 2010, 2012 kind of period when a lot was happening. And I think a lot of people are curious. A lot of people don't understand and want to know more. It's beyond their understanding of what's happening in their social world. And then some actors, right, use this to foment criticism of the direction the government is taking or so on. It creates some more tension. And ultimately, shortly after some of these reports and conversations, right, we see an increase in arrests, criminalization, policing of spaces that are community spaces. So in the case of Malawi, that's the arrest of the couple that's eventually charged and found guilty of sodomy. That's the raiding of organization offices in Nigeria. That's the adoption of the same-sex marriage prohibition bill, which actually has a very broad set of provisions to criminalize LGBT work in really any kind of space or context. It becomes illegal to run one of these organizations, to have an event, to do various things related to this work. We see similar kind of backlash happening in Senegal following one of the international conferences that has a section focused on men who have sex with men in African contexts in 2008, with a lot of arrests happening in that period. And so it's certainly not it's hard to kind of understand our own role there, right? We want to do our work. It's important for that prevention side to make sure that conversation's happening. And yet there's also these other things that happen beyond that make people's lives even harder in that context once we've collected that data, right? I don't think we shouldn't collect that data. I don't think we shouldn't talk about that data, right? Those aren't the things that I'm trying to leave you with there, but the stories we tell about them have repercussions that are out of our control, I think, quite often, which can become very problematic. And so staying in the picture, I think, is a good thing to keep doing, to keep having that presence and advocacy to help folks representing those communities continue to have that space and opportunity to represent themselves, of course, too.
Can you say something about the ethical implications for us as researchers related to that?
Yeah, I think that's hard, right? The ethical implications of not doing the work are also problematic, right? In terms of, yeah, we understanding those pieces. Some of the things that I think are promising that have come out of this. So one of the papers that I mentioned that's close to publication is on Nigeria, and actually how the Same-Sex Marriage Prohibition Act that was signed into law in Nigeria in 2014 actually changes the kinds of mobilization that LGBTQI folks do. So they focus a lot more on legal and human rights documentation. They hire paralegals. They work to incorporate cis hetero folks in their leadership so that they have a different kind of visibility to government officials. and like kind of broker allyship and so on with other organizations. So it creates a different outcome, I think. And they continue to use HIV to fund their key work. So I don't think that there are, I think that there are benefits to this work as well that go well beyond that backlash piece, right? It kind of maintains that that work. It becomes the thing that sustains them through backlash, in fact.
Thank you.
Yeah.
Any other questions? Susie Hoffman says, I don't have a question, but I want to echo what Teo said, that this is fascinating work.
Thank you. Thank you. I know that a lot of us come to this space with a social justice mind and framework. And and I tell this to my global health students as well, right? We come to this work with that in mind or as a motivation. And so thinking about the many ways that we also are shaping the possibility for those outcomes in a global context through policy, I think is interesting. And the ways that these policies are kind of generating their own social change from the bottom up, right, is also a very important aspect to kind of keep our attention on.
Phil Kroniski has his hand up.
Thanks. Yeah, wonderful presentation. Thank you. I was just thinking about some of the ethical and policy implications, and wondered if you could speak a little bit about how you think, the interconnectedness of the current world, given digital technology, could be, posing new problems, but also create opportunities for connecting these groups in ways that wasn't possible previously.
Yeah, I think this is a really awesome time to be thinking about these questions. On the one hand, there are a lot of regional and kind of multi-country collaborations among these organizations. And these have helped, for example, when new laws are passed or are being considered by like a parliament, for example, the organizations have other resources, right? They understand the arguments that may or may not work in their favor, given that, another group that they are familiar with has also just challenged these in a different context. So I think that provides some opportunities for resilience, that sharing of resources and experience across contexts. Certainly in the context of thinking about, the kind of the more ethical pieces of, how these connections are changing things on the ground. I think we have also folks involved in this work, and especially at the International Development Partners, have become more cognizant of what they're doing and how they're doing stuff. So I think the Obama era folks were really trying to push a particular agenda and take a stand. And so we see that in, I interviewed some of these folks again in 2014, 2016, 2018, thinking about how some of their work has changed, and especially during the Trump administration, what kinds of things changed in terms of what they could and couldn't say. And one of the most notable things is that they start to become very cognizant of when to push and when to maneuver more behind the scenes. And so some of that maneuvering, I think, is things like working with other foundations who are going to directly fund some of these grassroots organizations, working with the organizations themselves to develop other kinds of fundable work, and working within their own kind of mission statements and institutional structures to shift some of the concern about men who have sex with men and LGBTQI groups just outside of the health and development kind of space, to think about it also in terms of other things they care about economies and education and infrastructure, right? And so they've been able to think about, how do we move this prioritization around to be reflected in our whole institution. And that's, you know, that's happened unevenly, but it is a conversation that they seem to be having in, you know, in their units. And, you know, how to kind of get other organizations on board to help them in places where they're not able to, you know, make a direct kind of link to some of this work, because that would be viewed negatively, because that would be viewed as like outsider meddling, because that would be viewed as not, you know, not respecting their sovereignty and so on. Certainly for some of these organizations too, they don't want to have like their, like the USAID logo or the DFID logo or something on their stuff as well, because that delegitimizes them. And so these organizations have also been, the international development organizations have also been flexible in terms of allowing the LGBTQI and MSM organizations to kind of take that acknowledgement off in certain settings.
Great. Yeah, thank you.
Thank you, Philip.
So our last question will come from Teo.
It's such a great opportunity to talk with somebody who really looked into these issues very deeply. So I have one final question that came up while you were talking. You showed the map of the world, and Africa was blue. That's where we started, and things have changed. But in a way, Africa was an exception in terms of attention for MSM. You link it to the fact, or in history, it's linked to the fact that heterosexual transmission was a much more important factor, at least in the beginning. Would that be the only explanation for the limited attention for homosexuality in Africa, or can you point at other historical factors that might also have played a role?
Sure, I think there was certainly some resistance that the WHO Global Program on AIDS folks had to deal with diplomatically in terms of making decisions about whether to kind of push for inclusion and delay getting programs and prevention started and surveillance started, or to you know, get what they could going and then try to amend it later, essentially. They didn't have a lot of data either way. There was some, you know, some very initial surveys that that did collect same-sex sex information, for example, in Kinshasa at the outset, right? And this was, I think, thought to be limited enough that it was not going to be the focus, given, you know, the size and speed that of the epidemic people were trying to work with, I think. I think this was a difficult thing to talk about in African context, but not like it's also a difficult thing for folks in that time period to talk about with country level leadership in a lot of places.
Including the United States.
Yeah, including the United States. So I think all of those things actually are very important to this story. But the thing that I would like to leave you with is that folks kind of understood that this was probably a problem, at least certainly by the very late 80s and early 90s, 91, 92. You know, there was a commission convened to examine bisexuality among men in international contexts, which included information from South Africa and Cameroon. So I think like there was certainly this idea percolating that we were going to eventually have to work on this, but it wasn't a thing that folks had enough information on to actively pursue in a diplomatic way that I think made it take a back seat, given all the other social cultural things around same-sex sex.
Thanks.
All right, Bob, I'll turn it back to you.
Okay, yes, no, sorry, my internet's been a little bit unstable the last couple minutes. I hope you can hear me. Again, gratitude from all of us to both Yusuf and Tara for really excellent, thoughtful, and very important, timely presentations. We really appreciate you joining us today. And we look forward to future collaborations and conversations with you. Please, everyone, have a good rest of the day and join us on October 21st for a special rounds with two of our former postdoctoral fellows, Brian Dodge and Rogerio Pinto. Hope to see you then. Take care, be well. Take care. Bye.
Thank you.